All right, very good. I think we have a critical mass, and so we will go ahead and begin our program. So, good afternoon, everybody, and welcome to a conversation on resilience and recovery. We are beginning this conversation with a live demonstration. When the forecast changes, you adapt. And so, thanks to the snowstorm, we are trading an in-person gathering for a virtual one, but we are very glad that you have all managed to find your way here. My name is Lindsay Stark, and I'm a professor of public health here at Washington University. And on behalf of the School of Public Health, I would like to thank the Provost's Office and the WIDE series, as well as the undergraduate program in Public Health and Society, for helping make today's event possible. Convenings like this one are central to who we are as a school, and they provide spaces where we can grapple with the hardest questions in public health and offer opportunities to learn from a wide array of experts, including those doing work on the ground. So today we are here for a conversation about what happens to children who experience war and how they find their way back. What does recovery look like when you've witnessed and in some cases committed acts of violence before you've finished adolescence? What role do families and communities play in healing? And what can research teach us about resilience that actually translates into action? Our guest, Dr. Theresa Betancourt, has spent more than 2 decades answering these questions. She is the Salem Professor in Global Practice at the Boston College School of Social Work and Director of the Research Program on Children in Adversity. Her longitudinal study of war-affected youth in Sierra Leone has followed former child soldiers for over 20 years and has led to interventions now being scaled in Sierra Leone, Rwanda, and refugee communities here in the United States. She's advised UNICEF, the International Rescue Committee, the World Health Organization, and the International Criminal Court. Her new book is called Shadows into Light: A Generation of Former Child Soldiers Coming of Age. Leading today's conversation is our dean, Sandro Galea. Sandro is a physician and epidemiologist whose scholarship has shaped how we understand the health consequences of trauma, disaster, and social inequity. Earlier in his career, he served with Doctors Without Borders in Somalia during a period of intense civil instability, an experience that informed his lifelong commitment to understanding population health and one that certainly has relevance to this conversation today. Thank you very much for joining us, and over to you, Dean Galea.
Thank you. Thank you, Professor Stark. And thank you, Professor Betancourt, for joining us. And thank you, everybody, for joining in this conversation. It's really wonderful to be here. As Professor Stark noted in her remarks, Professor Betancourt has a new book out called Shadows into Light, which is a really remarkable book. I would recommend it to everybody. And Theresa, congratulations on the book.
Thank you.
So I want to start not talking about the book directly, but actually I want to talk about the work that informed the book and the relationships that made this book possible. So let's go back to Sierra Leone. You've done a lot of work in Sierra Leone for many decades now. So how did you first come to Sierra Leone? What drew you both to the country and to the questions you were asking and to this really difficult topic about child soldiers?
Yeah, great. No, it's really important that you start with the team. And I just want to thank you all for having me here for this amazing event and conversation. And I could not have done this without the amazing people behind the scenes in this work. I first went to Sierra Leone in 2002, and that was after I had spent some time at the United Nations High Commissioner for Human Rights and met many of the big NGOs working on humanitarian emergencies, had been mentored by an amazing social worker at the International Rescue Committee, Marie Lasoudière. And she knew of my background in child mental health, my interest in child rights. We'd worked on the big UN report, the Graça-Machel report of the impact of armed conflict on children. And I had gone with IRC first for the Kosovar crisis in Albania to set up emergency education programs, and had worked with them on the Ethiopia-Eritrea border. So we had some mileage behind us. She called me up and explained that IRC was helping with the resettlement and reintegration of children who'd been abducted into armed forces and armed groups in Sierra Leone, and that we had no idea about best practices in this area, really no literature or no research on what makes a difference in terms of what are evidence-based practices in such reintegration and the lives of young people after an experience like that. And the idea was, could we use this to research the topic and start a study together? And so we wrote a few grants to the MIT Mellon Foundation. Marie de la Soudière introduced me to Moses Zombo, who wrote the foreword to my book. And that is the beginning of something wonderful, because I got out to the field. I met these committed staff who were local Sierra Leonean staff working with the International Rescue Committee. But now we were going to do something different. We weren't just doing services. We were going to train the team to become local researchers. And that led to, everything from ethics training to what would be the instruments that could work. We had colleagues who had adapted a measure that was in the Creole Sierra Leoneans, the Sierra Leonean language. And at the time, we didn't have a lot of money. So we were just interviewing in certain domains of life of children as they passed through this large interim care center that the IRC was helping to run. And interim care centers were sort of the response with abducted children. So they'd negotiate release. They'd bring them to a place where they could be safe, where they had their medical needs met, they had shelter, they had food, they had psychosocial activities. And as the children began to know the staff, they'd interview them and using what's called a tracing interview. Where was the child last? How'd they get involved in the armed group? Who might still be alive? What were their thoughts of going back home? And then armed with that information, social workers would try to connect to the family members who'd been identified and see if the children could go back home. So that interim care center became the hub for our research, and it was serving 5 districts in Sierra Leone. And we just took the list of children, 10 to 17, who'd come through the doors in the most active 8-month period of reintegration, and we invited those children to be in the study. We tried to do a door-to-door sample to have a comparison group of non-child soldiers, and found out that because there were so many self-reintegrated young people, that method really failed. We found a lot of young people who hadn't gone through interim care centers had just made their way home when the war ended. So it became a huge study of a cohort of former child soldiers, 529 of them, a third of them female, all of them 10 to 17 at the end of the war. And we've followed their lives ever since, from 2002, 2004, 2008, 2016. And then most recently, we just finished data collection in 2025, the 5th wave.
So this is my next question, which is, could you imagine that you were going to be here, I guess, almost 25 years later? And, what have you learned about, we'll get into what you've learned from the topic, but what have you learned about actually creating something that lasts this long from this process?
Yes. So I could not have imagined this, but as we embarked on the research, I began to realize this was such a gap in the literature on the mental health of war-affected children. If you look at the studies out there, and you're an epidemiologist, you've worked in this area, there's a lot of cross-sectional research. So there's a lot of studies that more or less pursue the research question, is war bad for children, in a cross-sectional way, right? They ask how much they've seen countless horrible events, how much loss, how much personal injury, fear, and then how bad their mental health is in a snapshot. But we did not have a lot of work that was developmentally informed, longitudinal, and that thought about the life course perspective on well-being and mental health. And once you start to move into a life course perspective, you can start to ask questions about trajectories and the different paths that certain people may be on, more risky or more resilient, and then beginning to look at, if we're able to tease some of this out based on the timing of when we're doing our interviews, could we say what's modifiable that shapes outcomes? Because ultimately, we would want to stop wars. We would not want to have the lives of children turned into such horrors like what these children experienced. We'd like to prevent exposure. But the reality, we now in our lifetimes are facing the largest humanitarian disaster since World War II. There are 473 million children living in active conflict zones. If you take that to post-conflict settings, Rwanda, Sierra Leone, places that I've worked for a long time, the number swells even further. We don't have a lot of research that's asking these questions longitudinally, developmentally, and the other gap is services research. We aren't doing enough about what can help to overcome or mitigate some of these harms and help young people flourish. in these very degraded environments that they experience.
We have a number of researchers who are doing kind of longitudinal work here at WashU,
Yeah.
and people who are listening. What advice would you give to somebody who's trying to do this work in the long term?
Sure. I would say pick your partners well, and that might mean sometimes having to open new relationships and close others. I've in Sierra Leone worked really hard to find committed partners who we have a shared mission together. And I'd say almost all of our work sort of falls along the lines of what you would consider community-based participatory research, right? So from the very beginning, we were working with local teams, not importing people, but training up local individuals who could make this a career move to become trained in research ethics, research methods, to have them be a part of a team. And then, we've done our best work with Caritas, which is the relief arm of the Catholic Church. West Africa is kind of known for a long history of corruption and issues with governance. So to find Caritas and help them navigate, because I had partners before where money went missing or they were looking to get something else out of the opportunity. And sometimes you have to look really hard at that. Neil Tatlam and I have talked a lot about his work in South Sudan in the same way, like finding those partners and investing in the relationships and the partnerships becomes so fundamental. And then I would say the other issue is anticipating risk of harm situations and being prepared for that and putting in the sweat equity to know that you will encounter individuals in a suicidal crisis, in a risk of harm situation where there's unmet medical needs, where you discover violence in families, intimate partner violence, violence against children, and you're going to need to have a response. Rather than, figure that out once you're already, collecting data, you'll want to do the legwork to discover those referral pathways, how services can be paid for and covered, and how you can get people into longer term services as a part of just the ethics of encountering individuals who've been through very high trauma situations. And one of the ethical dilemmas that started to occur in our research was we realized that this study was really important and nothing like this had ever been done before. And the IRC had switched directions, different priorities. Marie de la Soudière retired. So there became a time where we were still doing the study, but IRC wasn't so focused on this population of children anymore. They had lost, the grants had closed out and that wasn't their focus. And we were needing follow-up for some of these young people. And we're seeing the gaps in the mental health services. So the ethics of this work became all the more fundamental because we had gotten to know the children through those reintegration centers, but the reintegration centers were now closed. The services weren't there, but we were still coming back. And they were so happy. They said, we're so happy that someone cares to even check in on us. We've not heard from anyone. But then it was an ethical dilemma for us because we're a research team. We're not the services team who brought the kids back to their families. And that really pushed us into a lot more advocacy work with the government and with local civil society organizations as well.
I'm going to move from the process to the content now, which is more interesting.
Yeah.
Before I do that, I meant to mention this to the participants in this earlier on. Theresa and I are going to talk for another 20, 25 minutes, but then I'll take questions that people would like to put forward in the chat or Q&A box. So please go ahead and do that, and I'll come to those in about 20, 25 minutes. So Theresa, let's move to a term that you use, concentrated adversity. Tell us a little bit what that means and why does it matter for when we think about trauma?
Sure. So sometimes in our field, you also hear the term polycrisis. The Venn diagram of the children you're talking about aren't just war-affected children, right? They're children living in extreme poverty. They're children living in a country where you have some of the highest rates of maternal mortality. Sierra Leone, if you're interested in the study of adversity, it's had layer upon layer. So not just the war, and the war undermined the health system, laying the groundwork for the historic Ebola outbreak, right? So 2014, 2015, Sierra Leone, Liberia, Guinea were hit hard. And in Sierra Leone, there were over 8,700 cases, nearly 4,000 deaths from Ebola. So now you put the Venn diagram, you're talking about children affected by Ebola, either directly or indirectly. And more recently, climate change. Sierra Leone, because of severe rains, shifting climate, much more intensity, has now had climate change related disasters, a historic mudslide in 2017 that killed nearly 1,000 people. And right in our research, a lot of the young people during the war, especially those involved in armed groups, were forced to take drugs and alcohol to inure them to violence. There's been very little health response to substance use problems amongst young people in Sierra Leone. And in the current geopolitical dynamics, there's now a trade of fentanyl, tramadol. It's being mixed with marijuana. There's a street drug called Kush that's raging the country. So the president has declared a national emergency on the Kush epidemic. And another epidemic, they've declared an emergency of rape and sexual violence. But all of these have roots in some of the same early, inequities, and in the conflict itself, and in the inability to restore health systems and governance since the war. Things have changed. Things have progressed in Sierra Leone. I am very close to David Senge, who's now the chief minister of the country, and see new leadership emerging. The mayor of Freetown, Sierra Leone, is quite impressive. But it is a place that in so many ways, sort of like Haiti, you see polycrisis, and you can't neatly put people into one box or another. And you have to think that way in terms of what their lives are like and what can be sustainable, what can work in an environment like that.
At a very human level, there's in the population you have studied so well, there's this tension between trauma and resilience. Some of these young people, they really experienced terrible violence, and some of them committed terrible violence. So talk us through that. How do you hold both realities, the harm they experienced, the harm that they caused, both in your research, but also in how you interact with them as humans?
Yeah. So I always put the human first. And I think in working with children, especially when we look at why children were involved in the war in Sierra Leone, they were involved because no one wanted to fight for the Revolutionary United Front rebels and their movement. And so they began abducting children. And one of the things they would do upon abduction is force children to commit atrocities against loved ones, neighbors, village leaders, with the idea being that they could sever ties, that young person, if they'd done these horrific things, they'd never be able to go back home. That would mean they wouldn't run away. But the reality was, at the end of the war, you had 20-some thousand children involved with armed forces and armed groups, and there was a big debate about what would be in their best interest. Should they all be seen as a lost generation? They should be institutionalized. They can't go back home. Or are there circumstances in which people could understand these young people were forced? It wasn't their choice. And everyone did horrible things to survive in the war in Sierra Leone. And there were these town hall sort of meetings, these community consultations around the time that young people were being released from fighting forces, coming to the interim care centers, but also going home. And these were town hall style conversations. They'd have the village elders, the parents, other youth saying, look, there have been young people from this region found. What are your thoughts about them coming home? And it was a way, one, to kick off a process of dialogue, but two, to take the temperature of the community and see, was this a place where young people could be reintegrated? And to Sierra Leone's collectivist culture, the sort of things you would hear in those places that were ready were exactly that. We all did horrible things to survive in the war. These children were forced. We know it's not their fault. Now, when it comes to the clinical side of that, though, there was a special court for Sierra Leone, which means that they tried only those most responsible for leadership roles in the conflict, the abductors, not the children who were abducted and forced. But there was a blanket amnesty passed, and you can imagine the IRB conversations we've had to have with talking to the ethics committees about risks for young people being in our study and how we were going to protect knowledge about things that they did, because we do have sort of a war experiences questionnaire that goes everything from deprivation to victimization to perpetration questions. on the clinical side, though, this special court had this blanket amnesty, and I know a lot of people felt that the narrative of they were forced, it was not their fault, was very important from an advocacy and a rights standpoint, but maybe from a clinical standpoint, not as helpful in terms of processing the realities of what a lot of these young people face. And I have a colleague who I knew at Harvard Law School, who went on to be a barrister in Sierra Leone, and he was really advocating for a legal approach that would at least acknowledge some of the harms that young people participated in, to allow them to own them somewhat, and to process those experiences, because otherwise it's sort of like magic wand is waved, you were a child, these things, we move beyond it. So it's a very mixed bag. And I would say, in the young people we've gotten to know in our study, they are reflecting on what they've been through a lot of the time. And there is still that human need to process those experiences that were extremely frightening and done under huge duress.
What surprised you about those who struggled and those who recovered well? Were there factors that you might not have expected?
There were. I don't think I saw this gender dynamic coming that started to become very clear in our research as we began to unpack who's doing well and not doing well over time. I was teaching a class earlier today and showing them some of these latent class growth models that we made, where we looked at family acceptance and community acceptance, and then mental health outcomes. And we see that over time, if you use multiple waves of data, you sort of get this class of kids. It's about 66% who came back to relatively good family acceptance and community acceptance. And then you see this group that we would call the social improvers, right? They were highly rejected at first, and then family acceptance, community acceptance has gotten better over time. And then you've got this 10% of always rejected, always struggling with their family relationships. And it's that group, when you compare them to the socially protected, that have 3 times the risk of clinical thresholds for anxiety, depression, PTSD, much more likely to have been involved with the police, much more likely to have attempted suicide. There's this sort of class of those most at risk, and a lot of them are male. And when you look at who was rejected after the war and experienced high levels of community rejection, family rejection, it was the females. So after the war, there was this sort of perception, these girls are impure, they've been with the rebel forces, they've been sexually violated, they're equivalent to prostitutes, this sort of rejection. And then with time, something about perhaps the ways in which women navigate the world, the connections they have to one another, the way they get help from others, we see in terms of mental health and community and family acceptance, the girls have entirely changed places with the boys by the more recent waves of data. And the ones who look most at risk are largely male. And I sort of wrap the book around these 2 stories. If for those of you who have the chance to read it, the young man we call Sar in the book is a great example of this. This was a boy. He was a toddler when he was taken. He was with his grandmother. They were gathering firewood. The rebels surrounded them, and the grandmother pleads, please don't take, he's just a toddler. Why would you want a toddler? But the idea that they had was there was a rebel commander. His wife was expecting a baby. They wanted a playmate and a helper. And Sar really struggled to find his family because he'd been so young. No one knew what it looked like. Many years later, when they were reintegrating and showing the photos of children who'd been found. And despite having a mother who loved him and a grandmother who loved him, the mother had suffered major mental health problems, poil at, as they say in Creole, her heart spoiled with the pain. And Sar, despite having these loving women in his life, he had an uncle because his father had died. They were living with the uncle, and the uncle rejected the boy. And when you don't have that strong family member to advocate for you, when you start to experience problems in the community, it can set off a very dangerous cycle. And Sar had learned to ride a bicycle to soothe his emotions in the interim care center. When he got back to the community, he wanted to ride a bicycle just like he had when the NGO workers had let him. And the uncle could have bought a bike, but didn't. Sar would rent bikes, but he didn't have money to pay. The guys who were doing the bike rental would beat him up. On one occasion, he pulled a knife. After that, he dropped out of school He had to leave the village. He was stigmatized. And the last time we interviewed Sar, he was 17, living in social isolation. And when Moses went back to interview him, and it's Moses and Musu, not me doing these interviews, my role, I take a lot of thought towards how this comes across to the participants. But I was so excited to hear how that interview had gone. And I could tell when Moses got out of the van, just the way he was carrying himself, that it wasn't good. And he said, Theresa, he's died. And Sarah was only 23 years old. So when we look at Sarah's story, it was one of, the rejection of his family, rejection of the community, inability of the attachment figures to pull him through, and then living in social isolation. And it's young people like that that we really worry about. There's another story I thread throughout the book of Isatu, who was taking her school completion exams when her school was raided. She was still wearing her uniform. She was sitting for the exams. Everyone started to run. It was frightening. She got separated. Of course, she wasn't near her family, taken by the rebels, taken back to the camp. And when she looked around the camp environment, she saw in another group of children, her sister huddled there. And the two girls, as they were held by the Revolutionary United Front rebels, I think it was 3 years, 4 years, they started to run interference for one another. And the thing about Isatu that really comes out in her interviews is she had a burning desire to pursue her education. And people started to see that, including her foster family. When she went back, they didn't have money. She couldn't, afford the books at school. But this foster family, this wasn't their biological child. They would turn on the power generator so she could study at night. She decided she wanted to give back. She wanted to study medicine. She got top test scores, and she started to get through medical school by borrowing the books of the other medical students when they weren't using them and staying up late studying. She got a scholarship to go to Latin America, and she's now one of the few doctors in Sierra Leone. So you can have these similar experiences of abduction, of separation, of being socialized by an armed group, but very different outcomes. And I think the male-female difference, really, I wasn't anticipating that. But now when I unpack it and think about that, I can see some of the hypotheses that might lead you to see how maybe over time women can navigate those experiences better, including the community and family relationships, where the men who have such, inability to talk about what they've been through, but also don't have the same social connections, they're some of the ones we worry the most about today.
Let me just build for a second on the community part of it, about community acceptance or rejection.
Yeah.
Walk us through what happens when a young person returns to a community that remembers what that person had done.
Yeah. So what happens is they get tested. And this is when I start to think about reintegration interventions, that this is exactly what we're not really doing, is preparing the young person for that test and for passing that test, and preparing the family for helping the young person navigate that testing, at least in Sierra Leone. It was very typical that people, as young people say, would provoke them, point fingers, call them little killers, call them names, and see if they would fly off the handle. They were trying to just sort of see, do you have rebel blood in you? Are you that bad kid we think you to be? And if you lost it like a SAR, you pull a knife, well, you've proven it. You've proven that you've got rebel blood inside you. Whereas those who could keep their head down, do pro-social things, try to make a contribution to their community, persist in their studies, those young people are the ones who made it. And our field today still has so much focus on these interim care centers. When you look at how reintegration of children separated, especially those abducted into armed groups or involved in armed groups by choice, there's still this model of the center. And the centers are beautiful. They've got yoga and art and they're fabulous, but it's a bit of a la-la land, because eventually where it really matters is once they return home. That's when the rubber hits the road. And we need, I think, to be studying interventions where we add a family strengthening component, and you prepare the young person for integration with their family, you prepare the family, you work with them when they're back together, and then you check back in and, maybe weekly and then monthly, and then titrate that and have booster sessions. That's not being done. That is not the standard way that reintegration looks. So that's why I'm working so closely with NGO actors, the UN, to try to shift thinking based on our research, but also mentor people like scholars I've mentored in South Sudan, Colombia, to see if we can't do a study of that nature. It still hasn't been done to this date.
It's really interesting actually. So you've written a lot about resilience. I've written a little bit about it. You've written a lot. Lead us through, how do you think about resilience without romanticizing it? I think there's always a risk when you affix resilience to the individual, to say, oh, look how strong they are, and in a way that lets the system off the hook. Talk us through that.
Yeah, no, that is a huge problem. I've seen it done. You know, kids are resilient. We don't need mental health programs. Look at how they're doing. We don't need much more than getting them home. They're resilient. I think it also is sort of flattens and narrows the true diversity and the richness of experience, right? I write in the book about the sort of superhero trope or the post-traumatic growth debate in this field, as if young people feel should get something from this. They should be better because of it, rather than accepting that for some people, they're not doing as well. You have the SARS of the world and you have the Asatus of the world. And as I see it, resilience is really the result of a process. It's not about traits of the individual. You can't go around fixing labels on like resilient kids. And the early resilience literature sort of read in that way, like, who are these super kids who get through really hard things? But the more sophisticated child development informed research is really starting to unpack those layers around the child, the social ecology, right? Yes, individual factors matter: age, gender, temperament, intelligence. Look at Asatu's burning desire for education. But what also really matters is what's going on at the level of the family and the way in which family interactions are shaped, and then the broader community. And that sort of Bronfenbrenner, all the way back to Yuri Bronfenbrenner, and those developmental nested ecologies of child development and how they're sort of interacting with one another. And there's modifiable elements at each level of that social ecology. And it's by maximizing those protective processes that we can shape, we hope, more resilient outcomes over time. And resilience is a process, not a trait of individuals.
I'm actually going to weave in a question from the audience, because it complements this one. So, you've addressed it beautifully, actually, I think, this notion about the environment around the individual in making for resilience. But the question is, says, I've worked with families and systems of care in a couple of states, and the longer I do this work, the more I am struck by children's sheer will to survive and be a beautiful human despite complex trauma. So can you comment about this in your work? So I suppose this is the other side of the conversation we're just having, which is, what about the individual's role in their own resilience?
Sure. I mean, it's huge because it can kick off a virtuous cycle, right? Like if you look at Asatu, she's a great example because this is our young doctor, right? She, no matter what, tears ran down her face when her friends who had gotten out of the interim care center visited her, and they're in their school uniform and she's stuck in the interim care center. She wanted nothing more than to pursue her education. And when people saw that in Asatu, they started to invest in her. UNICEF, they passed the hat. Everyone working at the UNICEF Sierra Leone office was chipping in to pay for her school fees, to help her buy books. Her foster family, normally foster families are really looking at their own biological kids, and maybe they'll host a foster kid. It's a part of their culture, the men Peking concept, but oftentimes they don't give them the same food or opportunities. But you had the foster parents turning on the power generator so she could study. So certainly it's a dynamic, right? It's that Bronfenbrenner. It's this shimmering, like you throw a rock in a pond and all the little shimmering waves go out. It is an interaction, the interaction of the individual forces with the forces around them. But that's not to say that we couldn't have done something more for SAR, right? Had we had interventions, we could have helped SAR's agency be released. He had a lot of wonderful things about him. He was a really likable kid. He was sweet. He had some problems interpersonally. He also didn't take care of his hygiene, so people would make fun of him with how he smelled. But had we worked with that family, I think with that uncle, like tapping into the love of the grandmother and the mother and helping SAR develop some emotion regulation skills, I think even the SARs of the world can unlock their human potential, right? And so a lot of our interventions now have been, how do we bring up all boats? So yes, there are going to be the people with that, in unbelievable drive to move ahead like the Asatus of the world. But that doesn't mean then we give up on the SARS of the world, because human agency, it's always there, but sometimes there are things getting in the way of it. And I think that's why I've worked so much in the mental health space and thinking about how do we bring up opportunities for everyone, not just the super performers.
Let me shift a little bit. Let's shift a little bit about the work itself and let's talk about the ethics of the work.
Yeah.
Talk us through about the ethics of studying trauma across culture. You're an American researcher working in West Africa. How do you navigate?
Yeah, very thoughtfully and slowly, and in partnership. So I grew up in a very small town in Alaska where I was a minority Gusuk in a Yupik community of, Yupik Native Alaskans in a remote part of the state, 3,000 people. That's where I was born. I was there till I moved to another part of Alaska for high school. And I learned from growing up in a culture like that to listen and to understand collective approaches to hard things. We saw a lot of hard things growing up in Bethel, Alaska, like the year our power generator caught on fire and in 90 degrees below zero, no one had power all of a sudden. We had to take people into our homes to get through those frightening moments. But there's something really beautiful about collectivity. And I think I've always carried that lesson forward. So when I went to Sierra Leone first, it was because I was invited. I had started to work with IRC. They had this program on the ground. They were open to having this PhD student who was interested in child development come out and see if we couldn't start some research. And I really, with Moses Zambo, who is a key character in the book, with Musu, John Bai on my team over the years, we've sort of been a committed team to navigating. And a lot of the time, I'm the person who knows the methods and I'm doing the training and the oversight, but I'm really careful about kind of staying in the background. I don't do the interviews myself. I think it is confusing to people if I'm now inserting myself into the dynamic. And I've always worked in partnerships and tried to really build those out from everything from ethical data collection, but also to services research. So when I first started thinking, we have enough here about the gaps, couldn't we be doing more on the mental health services front? Like when you see educational programs being rolled out in Sierra Leone, and without some attention to mental health, those programs are going to go just to the high functioning kids, exactly what we were just talking about. What could we do that could be feasible, acceptable, sustainable here, ethical? And so I sought out Dr. Adiyinka Akinslori-Smith, who's a psychologist based at CUNY. She grew up in Sierra Leone. She's an amazing, thoughtful person. And it was with Yinka and then another expert, Nate Hansen at University of Georgia. We wrote a grant. I was at the time at the Harvard School of Public Health, and we got a small startup grant for intervention development and went to Sierra Leone, met with people working with youth, met with youth themselves, started to look at evidence-based mental health interventions for kids exposed to violence and like pulling out common elements of them, like what could work in this setting that would fit the culture. And then with Yinka, we converted a lot of the materials we took from cognitive behavioral therapy, group interpersonal therapy, mindfulness-based practices. And a lot of those curricula, you'll have like homework assignments, but you're assuming people can read. And kids had 4 years on average abducted by an armed group and missed a lot of school. So you can't use the same approaches that are used in higher resource settings. And what Yinka and I were able to do is get a lot of proverb, get a lot of local perspective into that research so that the Sierra Leonean language is imbued throughout and that we're anticipating sort of the end user and that it's co-created. We also set up youth advisory boards, policy advisory boards, and those have been a process of bringing these interventions together as well as guiding the research.
Let me weave in another question from the audience. The question is there community-based work we could do based on this process of shimmering to create connection between people in the village and the children and show the humanity of these children and catalyze the wish to include them? What would that work look like?
Yeah, I think there is. I actually had an amazing experience related to this in my Rwanda work. We again, setting up community advisory boards, this shimmering idea. We had adults from the community who were parents themselves come in to advise the project. And at that time, it was one of our family strengthening studies, but we first did that in the context of HIV and AIDS. Families living well despite HIV and AIDS affecting them. How could parents continue to parent well? How could kids learn about HIV and AIDS and know that it was no longer a death sentence, that they could live well with it, their parent could live well with it? And we had these community advisory boards who were learning about mental health because we'd done all this qualitative mixed methods work on getting the local terms and the Kinyarwanda language for depression-like problems, anxiety-like problems. And we had this conduct problem that was the local, you measuring something like conduct problems in kids across cultures is ridiculous that we would ever take a Western measure. Like what it is to break the rules, the norms, is entirely construed by that context and that culture. And so we'd done this qualitative work. We had this syndrome term, and we were raising awareness with our community advisory board. And I had a woman in one of our subsequent sessions come back and said, after we had that discussion about child mental health, and we were talking about these problems like TROTAM and Malwar, I then thought about this child in our village that I know, and everyone's always saying he's such a bad child, and he's just a kid that should be thrown away. And I realized he's suffering. It's not that he's a bad kid. He's showing mental health distress. He's a kid in suffering. And so I actually took this kid into my own home as my own. And this community advisory board member, just like in the Sierra Leone more collectivist culture, she had adopted this young boy who'd been on the streets, and he wasn't easy. She had a rough go of it, but she had a whole new perspective on him as a child in distress who'd been through really horrible things, and she stayed committed to him. And just like we see in the families in our study, there's so many stories in the book about tough times when a parent or somebody else, it could be anyone, and there's that famous quote, I think it's also Yuri Bronfenbrenner, that every child just needs someone who's irrationally crazy about them, just committed to them. And this kid turned around. He turned around, and it was because of the love, the commitment, but also the sort of awareness of this woman in the community who started to see him differently. And I do think that sort of shimmering can happen. I think you're seeing it now in Minnesota. I think you're seeing it when anytime people stand up to injustice or take a stand against things that are unjust. I think it's quite possible. But sometimes I think in child mental health services, at least in this country, we stay in our clinical lane a little too much. And we aren't really thinking of the community-based supports in the ways I've seen happen in Africa quite beautifully.
Let me, before I move to my next question, I'm going to combine three questions from the audience. All three congratulate you on your body of work, and the questions generally are based on what you've learned in Sierra Leone. What do you recommend to the broader global community interested in developing programming that allows us to deal with these polycrises that are faced by young people? And some of the participants have mentioned trauma going on in Middle East, Latin America, Eastern Europe, and Haiti.
Yeah. So you all are so well positioned, and now with this amazing dean and this amazing School of Public Health at WashU, what the world has not been doing is system strengthening, especially in mental health and social services for war-affected populations. And we have not been doing implementation science. When I started way back when, 1995, at the United Nations with the Graça-Machel study of the impact of armed conflict on children, we didn't know it worked. And we've had now 30 years of trials, so many RCTs, showing that evidence-based mental health interventions, common elements of them when adapted to culture and to context, even when done by non-specialists, by extension workers, community health workers, they can have meaningful impact on mental health distress. But that's where we're stopping in this field. We are publishing RCTs. And so the agenda ahead is an implementation science agenda, and it's a health system strengthening agenda. And it's helping us shift to questions of reach, scale, sustainment, quality. How do we think about fidelity? How do we think about competence? How do we think about if we're going to use task sharing? How do we use technology or different strategies for supervision to ensure that we do no harm, that we do high quality work? How do we work with policymakers to overcome stigma, to get adequate budget, to have investment in human services professionals and a workforce for mental health? These are things right now we don't see enough of. And I've more recently been looking very closely at my own experience with the US National Child Traumatic Stress Network, which 20 years ago started with a handful of clinicians and researchers saying, we've got these trauma-informed evidence-based mental health interventions, but we're not doing them at scale in the US. And now here we are more than 20 years later, they've spread to 198 settings. Almost every state in the United States now has a National Child Traumatic Stress Network site, where they have a level 1 coordinating body at Duke, UCLA. Level 2 sites are intervention development and testing sites. We have one at Boston Children's Hospital. Then the level 3 sites are the treatment development sites. And they get the money to do the thing, but the thing has to be an evidence-based trauma-informed intervention. And they incentivize the relationships. They incentivize the research sites to work with the clinical services sites to train up evidence-based interventions, establish communities of practice, test strategies, try out new models that come from local lessons learned. We are not doing this globally. We are continuing to do cross-sectional studies and then RCTs. We are not doing the science of scale. We are not using the tools at our disposal. So I think coming here to WashU, which to me is like the mecca of implementation science, it's where I came and I did IRI for 2 years, met amazing mentors like Anola Proctor, Ross Brownson, Greg Ahrens, Brian Mittman. So grateful. You have so many amazing students, faculty, collaborations. I think there's a huge space for people to get involved, but it also means pushing beyond the cross-sectional studies and pushing beyond just RCTs.
Let me combine that a couple of questions from participants, and it's about the connections between this kind of work that you've done in Sub-Saharan Africa and how that informs the work we do here in the US. And you hinted at some of this in your remarks earlier. So how do we, I think there are many sub-questions here. Like, what do we learn from this work in Sub-Saharan African context that is applicable to the US? And how does one think about developing ambitious population health science that draws on global lessons and that helps us address some of the very real challenges that we face in this country around issues of trauma and its consequences?
Sure. No, growing up where I did in Alaska, in the indigenous villages where we didn't have plumbing, we didn't have paved roads. To me, working in Sierra Leone has so many parallels. And I think constantly about this question of reciprocal innovation. So how do we take innovation born of scarcity from very low resource challenging environments to very low resource challenging environments everywhere, right? So I think that the mental health models we've been doing in Sierra Leone, Rwanda, and other places would work just as well, if not better, in the Yupik villages of Alaska than what they're trying to do now, which is you have your psychologist and maybe your social worker, and they fly them out once a month, and they've got like a jam schedule of clinical services, a lot of telehealth, which is very exciting. I think there's been a lot of mHealth and telehealth in low resource settings. I think in the new Make America Healthy agenda, this concept of reciprocal innovation has to be baked in front and center. And I think global health has a huge role to play because we've had to innovate. We've had to work when there were no systems. And we've had to co-create. We've had to think about context. Whereas the way we approach mental health and social services in this country sort of waits for the highly trained professionals to get the job at XYZ agency linked to the state initiative. But we're not doing enough in prevention. We're not doing enough community-based. And I think the movement towards community health workers and task sharing and having treatment teams that are more broad could really help us get out of this dynamic of long wait lists and people who don't know the language, don't know the culture. I work on refugee topics in the United States, actually. And thinking reciprocal innovation. After the Rwanda Family Strengthening Intervention, we received a call from the Lynn Public Schools in Massachusetts because they were getting hundreds of Somali Bantu kids fresh from the Kakuma camps in Kenya were settling into Lynn, Massachusetts, and they were saying, oh my gosh, these kids have behavior problems. Look at them. When I say line up for art supplies, they're shoving and pushing, and these kids, they've got so many difficulties. But then when we came in and talked to the parents and talked to the teachers, we came to find these kids had freshly come from Kakuma, and to survive in Kakuma, if they were distributing food, you had to shove and push to the front of the line. And they were using skills that were real in the environment they used to live in, but they didn't fit anymore. And the teachers were upset that the parents weren't coming to parent-teacher night. But when you talk to the parents who are Somali, they say, well, in our culture, that's disrespectful. You don't insert yourself into the affairs of the teacher. You respect the teacher. You stay out of their hair. But in America, we expect those teachers and parents to be talking, and the parents are advocates and they're coming to meetings. So there's this huge disconnect. So we started to partner with the Somali Bantu community to adapt the family strengthening intervention from Africa for African diaspora back in the United States. And then we came up with a model done by refugees for refugees. And we had NIH grants, a R24, CBPR, then a U19 grant to try these out in 2 different cultures. We started working with Somali Bantu and then Bhutanese. So the old refugee services model was you get one group like the Hmong speaking Cambodians, and you make the whole clinic Hmong and all the clinicians are Hmong speakers. But then you get Liberians and Congolese. What are you supposed to do? So our idea was, can we have a core model that if it's done by non-specialists and they all uphold the core model and principles and they speak English, but also their local language, can there be cross-site learning across multiple cultures and multiple groups? And we were able to prove, yes, you could do that. And not only with the Somali Bantu and the Bhutanese did we now have mental health promotion done by refugees for refugees who are non-specialists, who are well-trained using an evidence-based model, going to homes. When the Afghan crisis hit and 90,000 Afghans with their families came to the US, we were able to pivot. And we quickly used the same field methods that we used in Sierra Leone and Rwanda, now in the US military bases where the Afghans were being brought. And we got at the terms for mental health problems in kids, for good parenting, for protective resources. We used that in adapting the intervention manual, co-created it, set up the advisory groups, piloted it. Now we're scaling that within the state of Michigan. So I think there's so much space here in the US to take innovations. Why do we have to keep thinking in the old way? Why can't we start to look at what global health has had to do because of scarcity and all the innovation that exists there and start to use it to address health disparities here in the US?
You've talked a lot about things which I think would sort of fall under the umbrella of making interventions culturally appropriate. Can you reflect for a second on what elements of interventions might be culturally universal?
Culturally universal, I think human connection to me stands out. I love the mHealth movement. I love all the app-based everything that's happening. I do think, though, even in our own work, how we're starting to think about mHealth and digital technology is as a facilitator for the human contact of working with people. I do think for some common mental illnesses, people who have digital sophistication and don't like, the interpersonal intensity of working with a mental health professional, that can be plenty. But I do see time and time again in the stories of the young people in our book who've come along to flourish despite all they've been through. And when I look at stories of transformation, like the story I told you about in Rwanda, there's this element of humanity, human connection. And I think, to me, that's a universal principle that I've seen as a protective resource, whether it be a more therapeutic role or whether it be naturalistic supports, and that Yuri Bronfenbrenner comment about having someone who's committed to you to make it through difficult times. I think when we look at language, we almost always find that there are problems akin to sadness that never leaves, or worries or rumination, or feeling frightened, fear. There's almost always these sort of syndrome groups, but the question is, how do we find their words for it rather than taking US measures? And I think in global health, there's been far too much reliance on Western standard measures, and we find ourselves showing up in different countries and talking about the different indicators and things like I feel blue. And how do you say that in your language? Instead of what is your word here for this kind of problem? Is there a problem? What we often start with these like qualitative methods that we just say, what are the problems of children in this refugee camp or children who've gone through the war? And we let all problems come. But we're really probing for problems of thinking, feeling, relationship, those mental health issues. But when you do that sort of free listing approach, you can get all sorts of things. And we did that in the camps in northern Uganda. And we also did it in the military bases with Afghans. You hear of all the priorities of people, but then within that, you can pull out the problems of thinking, feeling, relationship, and get at those cover terms. So yeah, I think there are universals, humanity, and also getting at language.
Can I ask you one last question from the participants and one from me, and then we'll wind down. What advice do
Okay.
you have? The question is about trainees, but I would extend it to trainees and everybody who is doing this kind of work in terms of keeping an eye on your own mental health when you're dealing with work, we're dealing with polycrises, trauma, complex situations like this.
Yeah, no, it's a really fundamental part. I do not in any way minimize how heavy it can be to do this kind of work and to surround yourself with people to process stuff with. I think that's why our team, we've always sort of had this team approach and debriefed and checked in with one another, self-care, and just sort of knowing when you're getting burned out and need to do some self-care because these are tough situations. I also think there's an important choice to make when you were talking about Northern Nigeria and what advice I would have for people embarking on this kind of work. It's also to find those partnerships that bring you joy. And there are, certain groups and individuals that I've had, I always say with Sierra Leone, it's given me much more than I've ever given it. Like lean into those partnerships that bring you joy. And sometimes you might say no to things because they don't feel right. And I certainly early in my career was asked to go to different war-torn places and work as a mental health clinician. And I never felt okay with that. I don't know the language, the culture. I would know the first thing about how to think about me as the responding clinician in this sort of setting. But I do know how to facilitate, and I do know how to bring people together and convene and problem solve and come up with collective solutions. And that's why our very early work was on psychoeducation and also educational settings and making, relationships, stability, predictability, something that was present for kids who were war affected before we ever went on to try to think about mental health. So I think leaning into the things that bring you joy and also finding, that element that you can make a meaningful difference in that maybe wasn't being done before. And I think we all have a role to play in that.
So you've done remarkable work for the past 2.5 decades. I really admired your work. And we are in 2026 in a difficult time in the world. I think it is not a challenge to say that. It's a rancorous moment in the world, and it's a moment where a lot of things that you have writing about and been studying are not getting better. Things are getting worse. So in all of this, what gives you hope? What in this moment gives you hope?
Yeah, I still have a tremendous amount of hope. And I think sometimes out of crises, there are opportunities. And in seeing the attention to, first of all, the war in Ukraine, because it's right on the doorstep, it's in Europe, has raised this issue to the forefront more than it's ever been in the public eye. And then all of the movement and concern and humanity brought to look at the situation, the conflict between Israel and Hamas and the fallout in Gaza. I think there's been a window of opportunity that I haven't seen before because this is an issue that's much more in the public discourse. It couldn't be a worse time when it comes to funding or trying to pull off ambitious things. But I've actually, in this moment, felt at this point in my career, I'm putting my shoulder to the stone even more firmly of trying to push ahead an implementation science initiative to spread trauma-informed evidence-based mental health interventions in war-affected settings. And we have to think about this for climate change, For other natural disasters, look at the fires in the state of California, look at other climate change related disasters in addition to wars that continue to rage, so that we do things differently. I don't think we need many more stories of how bad war is on the lives of children. I don't think we need more cross-sectional studies tallying things up, but I do think we need much more thoughtful, developmentally informed research. And I think we need much more services research and much more serious, rigorous implementation science. And those of us who have that background, who have a passion for this, I think it's time to lean in rather than lean out.
Professor Betancourt, Theresa, thank you. Congratulations on this really terrific book, and thank you for the work that you do and you have done for so long. A thank you to our participants, and I'll turn this over to Professor Stark for the last word. Lindsay.
Thanks so much, Dean Galea and Professor Betancourt. I will just say that those of us who have been working in the field, and I know there are a number of us on this Zoom here today, um, have watched and admired this work. I remember when you were in year 3 of this longitudinal study and thinking, wow, this is revolutionary. Nobody has been able to look at these kids and follow them and learn from their trajectories in this way. And so here we are, 20 years out, and the data and the science that you've helped advance in this space is truly remarkable. So thank you for your contributions. And thank you also for the forward vision. I think, it's a good charge for us who are looking for how to move forward. Thanks to everybody who was able to attend today. Just a reminder to look into Theresa's book. It's really so important and a wonderful, important piece of learning for us all. And we look forward to seeing you at future events and wishing you all a good evening. Thank you.
Thank you so much.